Carlos Arnaud, yo soy médico psiquiatra y psiquiatra de Enlace y coordinador del curso de alta especialidad de Psiquiatría de Enlace del Tec de Monterrey. El día de hoy vamos a tener un invitado de lujo en nuestra sesión académica internacional con la doctora Sher. Ella está en la Universidad de Stanford. Ella es profesora de psiquiatría asociada. Está en el área de psiquiatría de Enlace, precisamente en el área de Stanford. Ha publicado muchos artículos, ha publicado uno de los principales libros que todos los psiquiatras de Enlace debemos de ver, de conocer, que es el libro de trasplantes, de aspectos de cuidado psicosocial en los trasplantes. Y bueno, nos da mucho gusto que la doctora haya querido participar y aceptar en esta sesión, hablando precisamente de los retos de salud mental en tiempos de COVID, en pacientes dentro de los protocolos de trasplantes, tanto dentro de los protocolos como ya pacientes trasplantados. Dr. Lisa, it's a pleasure to have you here. Thank you very much to accept our invitation. Most of the people that are here are CL psychiatrists from all around the country and also from Latin America. And also we invited a lot of medical doctors in the field of transplantation. Thank you very much for being here. So you can share your screen, and welcome to Monterrey and welcome to the Tecnológico de Monterrey. Thank you very much.
Okay, thank you. Okay, I'm going to share my screen. All right. Okay. All right. Well, thank you so much for having me here. You know, definitely, you know, one thing that COVID has provided is a very easy way to travel places and connect with people around the world. So I really appreciate this opportunity to talk about this very interesting topic. So this is a new, you know, presentation that I, you know, put together because this is really a new emerging, obviously, you know, theme, mental health challenges in transplant patients in the times of COVID-19. So thank you for the introduction. I have been on faculty at Stanford as a consultant liaison psychiatrist for the last 8 years, working very closely with Dr. Maldonado, who actually has inspired me to go to CL Psychiatry. And I started there as a resident and then, you know, progressed to being a fellow. Now I'm there on the faculty. So my subspecialty is working with transplant patients, in particular lung transplant patients. So you will see pretty much all of my examples are from my lung transplant patients. But also I work with our cystic fibrosis program. And, you know, I'm their director of psychological and psychiatric services. And of course, many of those patients either are actually lung transplant recipients or at some point, you know, unfortunately will require lung transplant. So there's a lot of, you know, crosstalk between those two programs. So, you know, during the COVID, right, I'm at Stanford in California. Definitely, you know, I have been working very closely with our CF patients, with our lung transplant patients, but also initially had really not an opportunity to provide support to our ICU physicians and our ICU fellows, especially in the beginning of the epidemic, when it was just coming, when we were watching what was happening in Italy, and when we knew less about the virus, right? And it was definitely even scarier time. At this point, it almost seems like it's a new crazy normal. All right. So what I will try to cover today is just talking about the effects, some of the initial effects of the COVID-19 pandemic and transplantation, just touch on a little bit about, you know, what are the programs potentially doing. We'll talk a little bit about some initial outcomes in transplantations in the context of COVID. And then we'll talk particularly about, you know, well, what about the psychological and mental health concerns and challenges and in our unique population of transplant patients. We'll talk about some particularly unique considerations, such as what about alcohol use, right, which is obviously on the rise? What about the new cases of transplantation in COVID-19 patients, right, the new territory? And then just we'll start, you know, maybe even brainstorming together, what can we do particularly as a transplant psychiatrist, supporting our patients, our transplant teams, and also ourselves. So these are statistics of just that I borrowed from Johns Hopkins University, just as of few days ago, and obviously, unfortunately, the numbers are higher, but just, you know, we all know we're in the middle of this, you know, horrific pandemic, really living through these historical times, and just to orient ourselves, right, that there've been, you know, close to 24 million of COVID-19 cases worldwide, with over 800,000 deaths worldwide. US is unfortunately, has been leading with, reaching to 6 million cases and over 178,000 of death. Brazil is also, kind of very, very high amount of cases, over 3 million cases. Mexico, right, has been hit hard with 563,000 cases and obviously more at this point and over 60,000 deaths. So we all know these are historical, unprecedented times that we're living through. Something that I tell my patients all the time, right? I think really this is one of the biggest, obviously, challenges of our, of our generations. And of course, we, many generations, will be, right? We are living through this and we all are being imprinted by this experience. So how has the world of transplantation been affected by the pandemic? Well, first of all, right, there's of course effects on the donors, right? And especially initially, and I am coming, I'm sorry, from a lot of the US experience, right? This is my expertise and it's also, easier to research. But especially initially concern for decreased donor availability, right? Of course, especially the lung transplant recipients where unfortunately donors come from, car accidents, right? And with people, with lockdowns and people driving less, right? Good for the people, but not so good for donor availability in terms of just donor availability. And also, of course, living donation, has been decreased since it's not as urgent. And there's also been concern of infection to live donors, especially, and this has been one of the reasons to potentially put off those live donations, right? To preserve the resources and also decrease the risk to the donors. And of course, there is a lot of concern in terms of the increase of recipients, new recipients, right? People who are potentially at risk of contracting COVID-19 as being in the hospital for transplantation, but also, long-term recipients who, of course, are immunosuppressed. There is a theoretical concern of transmission from the donor to the recipient. We know that SARS-CoV virus has been isolated from lungs, from blood, right? It's been found in feces, in semen, so right, I think it's actually present pretty much in all organs. But so far, there have been no known cases of actually transmission from donor to the recipient. But we do know that recipients, due to their immunosuppressed status, right, are potentially at increased risk of contracting the virus and not doing as well. And also, these are chronically, ill patients or patients. Are you able to hear me still okay? Because it says my internet is having a difficulty. Okay, so I'm like, hopefully that's not a problem. But also there's a frequent visits to medical institutions, of course. And that increases the risk of exposure as well. And then there's availability of beds, ventilators, staff, right? So there are effects on the healthcare resource utilization as the intensity of cases in certain areas have exceeded available capacity, right? Where cases had to be put on hold. So there have been a lot of stratification efforts, especially in some programs, potentially to decrease who really needs the transplant right now, right? And where it is safe to get it. In addition to a variety of certification themes, we know that many, and this is a paper from March 2020, at this point it seems like a long time ago, but we know that obviously multiple countries and institutions have instituted pretty much universal screening of the donors through the nucleic acid testing. So donors are being tested. We don't know of any donor to recipient transmission, but of course there is ongoing increased risk to both donors and recipients. It's interesting, if we think about how has the world of transplantation been affected by the pandemic, and this is the US data, it's a little bit lagging as compared how the US transplantation numbers have been doing last year. But actually, in terms of the disease donor numbers, at this point, there's actually have been greater number of disease donor donations, transplantations in the US as compared to at the same time of last year. And last year was a really good year in terms of these donations. We see that living donor donations have decreased because these are not as urgent cases that can be put on hold. But overall, the field of transplantation in the US actually has been going steady. And I see that even in my own, Stanford program, that I see that there was a little bit of a lull in the beginning in the lung transplantation community, but now we see patients being transplanted. It's a different experience. And there's also additional concern, and I'm sure that's true for many other programs as well, right? Some of our lung transplant clinicians, they are also ICU doctors. So then you really have to think about that infection control, right? And make sure that, you the ICU patients get their care, but the transplant patients get protected from this additional risk of spread. But the transplantations are happening, and I will be very interested to hear what's happening in Mexico and Central America. But in the US, the transplantations have been happening with these new mitigation efforts. So what do we know in terms of the outcomes in transplant patients who do get COVID-19 so far? This is some of the data. There is more data coming out. Obviously, it's fresh, and we will all be looking forward to more meta-analysis of better studies. But these are some of the studies that have come out. So one study that from the New York Center that looked at the kidney recipients at end of March, looked at 36 consecutive kidney transplant recipients who tested positive for COVID-19. 72% of them were male, median age was 60, 39% were Black, and 42% Hispanic. And unfortunately, I'm sure as you guys are familiar, unfortunately, Black and Hispanic communities in the US have been disproportionately hit by the virus. And we potentially see it here as well. So 22% of these patients have been monitored at home, 78 were admitted to the hospital. 40% of the patients who were admitted to the hospital needed ventilation. And at the median follow-up of 21 days, we see that 28% of all of those patients unfortunately died. And that actually included 2 patients who were monitored at home, and 64% of those who intubated died. And yet, another study also at the New York from different hospitals, 10 patients, we see that again, 30% mortality in those patients within a few weeks. And in this study, 50% developed acute kidney injury. So unfortunately, really sobering data. And yet again, the early 2 weeks of the pandemic at 2 New York transplant centers, we know that New York was hit really hard, and now they're doing much better. Now this prospective study looks at 96 patients. This was a retrospective study, 96 patients with median age of 57 years, 46 were kidney recipients, but now we also have 17 lung, 13 liver, 9 heart, 5 dual organs. 3/4 of those patients were hospitalized. 35% required ventilation out of those who were hospitalized, but there were no ECMO cases. And so 26% of overall patients, and 1/3 of those who were hospitalized required ICU admission. And again, we see, quiet, unfortunate mortality was 20% overall, 1/4 of those patients who were hospitalized, and 1/2 of those who were admitted to ICU. In this case series, there were no episodes of rejection reported. And they did comparisons to just community data at the same time, where we see that unfortunately transplant patients here were hit with greater likelihood of severe disease, right? 39% as compared to 6% general population, and again higher mortality, 24%, as compared to we still have to figure out what the mortality is in general population. And yet again, another this is more systematic review combining a few of the studies. 39 cases of COVID-19. This is liver and kidney transplant recipients. And yet again, the mortality was 25%. We can see that there's a higher mortality in liver recipients, and these patients are approximately on average 5 years post-transplant. And the mortality, unfortunately, is sobering. And then out of the 23 kidney transplant recipients, who are also a little bit younger, on median also had 4 years post-transplantation, the mortality was 17%. And just as we see, but even more strikingly so, but just as we see in general population, age is the risk factor. And of course, that correlates with other comorbidities as well. There are some other data as well, where the results are a little bit more actually hopeful. And also this is data from earlier in the epidemic, at least in the US, where we did not know just as much. So hopefully these outcomes are improving, but this is some of the earlier data. I know that just recently, one of my lung transplant patients was admitted, and this is somebody who is 5 years after her lung transplantation, unfortunately in chronic rejection, was being reevaluated for transplantation, and that was of course placed on hold because of the pandemic. And we can just imagine what mental health effects that has. And she unfortunately got COVID-19, as well as her daughter and her mother. She was hospitalized at Stanford, and she got, sort of like the latest, at least, right, treatment that shows some hope, remdesivir, steroids. She did go to ICU, but she avoided intubation. Her lung function was approximately 37%, and she's actually at home doing okay. So, it's also very encouraging to see those patients who, you really worry seeing them getting sick, but they also pull through. So hopefully overall, this data is improving. So what are some of the psychological themes? And also this might be something that, we can talk about later in questions. So, I'm very, interested to hear kind of your experiences, but this is some of the themes that have been coming from my patients that I've been seeing, virtually, right? I'm seeing most patients in outpatient setting virtually, although there's also cases where, we do have to come in, right? Because obviously virtual telepsychiatry has limitation. But this is some of the themes, right? So one of my patients, 57-year-old woman, who I actually just checked in with her yesterday through telepsychiatry, status post-lung transplant, approximately 3-4 years. She lives by herself. She's isolated. Usually she sees her friends or her siblings, and her siblings are also older and have medical illnesses, right? So a lot of fear about contracting the virus, and this sense of isolation and loneliness, which many of us experience, and it's especially exacerbated in these high-risk populations. And we know that isolation and loneliness on their own, they have a negative effects, both on mental and medical health as well, right? So we see a lot of isolation and loneliness. Then there's also a lot of existential themes, right? Loss and grief. So this is an example of 43-year-old man with CF, who is just 1 year status post lung transplantation, and was, this is somebody who was already really sick for 3 years, deteriorating, right? Progressive lung disease, difficulty breathing, was not able to work, was so excited to get the transplant, and finally starts working again and traveling, and now again on hold. So this is actually a really traumatic experience for quite a number of patients. They feel that they're back again where they were just before the transplantation, right? And this is actually really triggering for PTSD for some of the patients, some of the same themes. I'm here by myself, I cannot do many things. And also feeling like precious time is being wasted, right? Transplant patients, particularly lung transplant patients, they're very aware of how much time they think they have left, right? The transplant clinicians, tell our patients that on average, they have 5 years. So some patients really have this mentality like, I'm going to survive to 5 years and I'm just going to die, right? But they have this, mental clock. So they really feel, oh my goodness, like this is very precious time is being wasted. So a lot of loss, a lot of grief. Of course, fears of infection, and even more so, right, these patients who realize that they're at higher risk, but to the point of potentially affecting maybe even their routine care. Understandably, many patients are worried about coming to the hospital, despite of the reassurance even, from their physicians. And then you wonder, right, how that's going to affect the long-term psychological, but medical health as well, right? We know that, people do not come to the hospitals due to their strokes or MIs because of the fear, right, of contracting COVID-19. So how many patients are going to suffer, right, because of their regular medical concerns? And these are not regular medical concerns, so our transplant patients are going to be exacerbated. And then there's themes of feeling, guilty and feeling like a burden. Yet another patient, 22-year-old man, few years after lung transplantation, who has younger kids, 12 and 15-year-old children, and feeling really guilty that his family has to be extra strict with social distancing because of him. That even if there is a chance for them to go to summer camps or see their friends, that they have to be extra strict because of the potential risk of infecting him. And sort of working with him, showing that, yes, they do have to be extra strict, but there's value in learning that compassion and caring for others, and how he contributes by obviously surviving the pandemic and being there for them. That's an important theme as well. Financial concerns, right? There's a huge financial ramifications. With one particular example, this patient got his transplant literally just a month before the really pandemic hit. And he's dependent on his wife's insurance, and his wife was laid off, and he lost the insurance. So I'm still not sure what's actually happening. And I know that our social workers are trying to help him to connect to kind of county programs, but then of course the copays will be higher, and how they're gonna affect the copays. So how is that gonna affect our patients as well? But there's significant financial concerns, and with people being laid off. Of course, there's fear and anxiety due to contracting the virus, as we already discussed. So this is the patient that I mentioned early on, the woman who was being evaluated for retransplantation, and then she got COVID-19, right? So I was speaking to her on the phone while she was in the hospital, and also my colleagues from psychiatry were actually seeing her virtually from the hospital and just expressing this frank anxiety and fear that death might be really imminent, right? Really feeling it being very close yet again, right? These patients who have been there once and now it's so vivid for them yet again. Thank goodness she's done well and she's elated, but we'll see what will be the long-term effect of this. And then just surviving the pandemic, right? What about those patients who are waiting for the transplantation, right? The patient who's pretty high on the list, and now the pulmonary rehab service is not available, right? Again, this is the patient waiting on transplantation because of the infection control, and he's deteriorating and staying strong, right? Keeping that muscular strength is so important, first of all, to remain a candidate, but also obviously to do well after transplantation. And now there's also limited support because fewer people are able to support him physically due to the risk of the infection. So just worrying, am I going to survive it? Am I going to get a transplant? So definitely there's a lot of themes, a lot of very valid concerns. So COVID-19 kind of and mental health, right? So there's just emerging data, and I will show you few articles that I have found on particular effects on COVID-19 in transplant patients' mental health. But of course we can extrapolate from what we know, right? We know that it has effects on COVID-19 survivors directly. There's obviously effects on all of us living in these times of the pandemic. And again, all of us, because we're healthcare providers, a very particular group, but effects on the healthcare providers, of course, have effects on our patients as well. So it's very important to consider that. So just a recent interesting article came out of Italy, looking at the mental health effects of recent COVID-19 survivors, and maybe some of you already have seen that. So they have evaluated 402 adults who survived COVID-19. A little bit more than half of them were male, mean age is 58, and they spoke with them. They conducted a clinical interview with some self-report questionnaires a month out of the hospital treatment, or actually treatment at home, because some of these patients actually go at home as well. And so what they found, right, there's sort of a third of patients have increased PTSD symptoms, right? A third have increased depression symptoms, 42% anxiety symptoms, obsessive compulsive symptoms, right? It's interesting because I think many of us, can be blamed now for having this obsessive compulsive symptoms of hand washing and, sterilizing the groceries, right? Sort of what is normal, what is not, right? All of that have been questioned. Many patients struggle with insomnia. More than half scored in pathological range in at least one dimension. So there's definitely acute mental health ramifications for those who have, survived COVID-19. Risk factors are female gender, which is not surprising, right? We know depression, at least might be in anxiety. Some anxiety disorders might be more common in females. Past psychiatric history, which is also not surprising. I think what is kind of a bit surprising and interesting is that actually patients who were hospitalized were protected. They had fewer mental health symptoms as compared to those who stayed at home. And also patients who were in the hospital for a longer time actually had fewer mental health symptoms in 1 month follow-up as compared to those who had shorter hospitalizations. So one of the hypotheses is actually, again, right? So maybe we see that effects of isolation, right? Not getting the support at home or even with shorter hospitalization contributes to mental health symptoms, right? So it may be also, it's obviously not just the sort of the fear of the virus, right? And the virus, but the quarantine, the isolation, all those other, right? The measures that we have to put in around it, but they can be detrimental as well. So just really, our patients really need support during this time, right? If we cannot see them physically because it's not safe, calling them on the phone, right? Zoom calls, right? FaceTime. So just really checking in, providing the support is really important. In general population, right? These are patients, these are people, these are all of us, right? Who have not had COVID-19, but who live in this pandemic, huge stressor. So 44% of patients, this is some, variety of meta-analysis and more coming out, are thought to be sort of affected by some measures of sort of quote unquote, vague, poor mental health, right? Poor sleep is common, just psychological distress, symptoms of depression, symptoms of anxiety, right? A quarter of patients have depression, of people have elevated depressive symptoms, a quarter have anxiety symptoms. I'm sure all of us would score high at this point in PHQ-9 and GAD-7 if we were to self-administer that. Some of the risk factors in general population, unsurprisingly, is prior psychiatric illness, right? For example, they found that people who have eating disorders have worsened eating disorder behaviors. Prior and current medical illness also is a risk factor for no mental health symptoms, right? So these are our patients, right? Our patients are living, obviously, with medical illness. We know medical illness is a risk factor for mental health concerns. Socioeconomic factors, right? Again, of course, right? Decreased social support. These are all known factors, and they're all happening at the same time. Increased exposure to social media, right? I don't know how for you guys, but I'm trying to stay away from Facebook these times because it is triggering, right? And everything is also politicized, especially in the US. So, social media exposure is really triggering. Healthcare workers is a risk factor, right? So we are, not surprisingly, we're in the profession that provides, we are a more risky population. We know that. And again, this is particularly focusing on healthcare workers, right? Many of us have poor sleep, right? And unable to sleep. Many of us report psychological distress, right? Many of us now report depression and anxiety, right? So we're not immune. We actually, I think, this is a tragedy what's happening, but I do think there are also some, positives that are coming out of it. First of all, the telehealth, telepsychiatry, that, teleconferences, even though it's always much nicer to meet in person, but it's also a plus. But also, now the emphasis that has been put on mental health, and we see a lot of in the media, sometimes media can be good, right? But mental health and mental illness in healthcare workers, which has been and kind of trying to destigmatize that. And these are the numbers, right? We know that healthcare workers are suffering. And also we know that, psychiatrists were always interested in that. We know this, that COVID-19 has a lot of neuropsychiatric and neurological effects, right? So this is important to know in general and in our transplant patients as well, right? We know that many patients present or at some point have olfactory or gustatory dysfunctions, right? Problems with smell or taste. It's up to 88% in younger patients, but kind of in all comers, it's approximately 30 to 40% actually. But younger patients might have even higher numbers. Delirium, not surprisingly, is super common. As a sales psychiatrist, I'm excited to see now articles on delirium in New York Times, right? And there's a great conversation about delirium. So again, maybe another good thing that's coming out of it. Catatonia, right? Now, we're not surprised by this as sales psychiatrists, right? But there are cases of catatonia, the case of encephalitis and meningitis, right? COVID-19 is isolated in CSF. We know that it's neuroinvasive, that potentially, right, through the olfactory bulb, it actually goes, right, to the brain. And maybe, right, some speculate that because it also goes to brainstem, that maybe the respiratory failure is not only coming from the lungs, but also that's kind of part of the brain effect as well. We see cerebrovascular disease, right? And some patients are presenting with cerebrovascular disease, right? Because of D-dimer elevations and coagulopathies. We see seizures because of multiple of these other etiologies. And there's also other kind of long-term effects as well. So, we know that COVID-19 has psychiatric mental health effects and neuropsychiatric and neurological effects as well. So, and we also know, right, there's obviously, this is why we are in this field, there's a very, intimate relationship between mental health and transplant. We know the increased risk of depression and anxiety in our transplant patients before the transplant and after transplant. And we know that at least the post-transplant depression increases mortality in transplant recipients in general. We also know that there are increased rates of PTSD in transplant recipients. Approximately, 20% of patients have some PTSD symptoms within 2 years after transplantation. We know that prior trauma is a risk factor for PTSD. And so now these patients, right, who have high rates of PTSD, they're living through yet another traumatic experience. So just thinking about what is that going to mean for them. Just some, data points just in general in mental health, right, in transplantation. So this is a study by Dr. Du from some time ago, but comparing lung and heart transplant recipients, right? And again, within 2 years of transplantation, approximately actually 18% of lung transplant recipients have panic disorder, right? High rates of adjustment disorder, especially early post-transplantation. PTSD, 14 to 15% in this study, comparing heart and lung transplant recipients, and depression is really common, right? Quarter up to a third of lung transplant patients and up to a quarter of heart transplant patients have had at least one major depressive episode within 2 years of transplantation. And we know, again, as I mentioned, that not only, of course, depression decreases quality of life, but it actually increases the risk of rejection and loss of graft and mortality in patients with depression. And it has been shown actually along, early post-transplant depression increases mortality risk, late. So at any point after transplantation, depression in transplant recipients worsens the outcomes, and it's not surprising, right? We can think about, well, what effect does it have on behavioral activation, right? Adherence, inflammation, and multiple other factors. And same thing for post-traumatic stress disorder in transplant population, potentially affecting the health negatively. So what about mental health implications for transplant patients in times of the COVID-19, right? So I'm sure there will be much more coming out. This is still so early, but these are some few interesting articles that I found, kind of looking particular on mental health in transplant patients. So this article comes from Hubei province in China, which is, of course, was one of the largest areas in China affected by COVID-19 epidemic, but also prolific transplantation area actually in China, which I learned. And, they perform, over 1,550 kidney transplants per year and over 400 liver transplant surgeries. So obviously very prolific. So multiple transplant recipients in the area. So this paper was very interesting. So they provided, they kind of discussed how they provided this, online, right, and virtual, systematic, multidisciplinary support to the transplant recipients. And actually I was very impressed. So you see how the cloud clinic was organized with multiple services. And I was just so impressed to see the mental health assistance and clinical counseling, right, embedded in this, right there, center and integrated. And so they actually analyzed some of the mental health effects on their patients. So they've conducted telephone interviews, February to April 2020. And these are some of the vague measures, but kind of interesting, right? So over 80% of their patients reported varying degrees of negative emotions, right? Not surprisingly, such as fear, difficulty falling asleep, right? And depression, 11%. There's a lot of worry about being infected with the virus, but also, worry about delaying the medical care, the hospital visits, which we do see happening, right? Patients are more afraid to come into the hospital. Of those, and again, right, and also worrying about what does it mean for them, that they are immunosuppressed, right? And this does place them at the higher risk. So patients realize that risk, they hear that. And of course, that further, affects them mentally. And again, it was great to see that there was one-on-one mental health crisis assistance provided in this cloud clinic service. Another multi-center online survey in February, kind of a week in February, in mainland China. So this was a survey conducted to the families of children in dialysis center. And some of these children were still in dialysis, but actually half of them got kidney transplant, but they were still followed by the dialysis center. So this sample sort of includes current dialysis patients, pediatric, and also transplant recipients. And it looked at the caregivers. So, we know that the mental health of caregivers affects our patients, right? So here we see that, not surprisingly, many caregivers report having difficulties and having worries, right? Kind of regarding, the next 2 months, right? About the future, the uncertainty, worrying about what's going to happen. And some of the most, in this group, right? They're worried about dialysis supply shortage for the dialysis group, and also availability or safety of having blood tests for the kidney transplant recipient caregivers. Caregivers had depressive symptoms and anxiety symptoms. So they reported that these prevalences were higher than in the general population, kind of in this area, which is approximately 3 to 4%. But actually, interestingly, according to them, it was actually similar to the historical prevalence of depressive and anxiety symptoms. So while there were increased fears and anxieties and worries in this group, sort of diagnosable depression and anxiety potentially was similar, but we will see, right? And sometimes we also see that our patients and our caregivers are more resilient, right? So it actually goes both ways, because we also know that there is, post-traumatic growth as well. A Belgian cystic fibrosis center, which also incorporated lung transplant recipients as well, provided an online questionnaire in April during the lockdown. And again, questioning patients about their quality of life and mental health well-being. And again, 30% reported loss of energy, sadness, discouragement about the future, negative thoughts about the crisis, right? Not surprising. 40% feeling helpless because they could not meet with their family members, experiencing increased levels of stress. and many patients had difficulty sleeping. And, you know, interestingly, right, so 50% experienced situation as worsening or reported they could not adhere to their routine care, right? And obviously it's very important for patients with CF, and it's even more important for patients, right, for transplant patients who we know, right, patients skip their, they skip their immunosuppressants for a few days, and that potentially might trigger rejection. It would be interesting to see, right, kind of, again, longer term effects of this phenomenon. And, you know, 3 people reported suicidal ideation as well. So there were crisis interventions, there's nobody attempted suicide. But it is important to know, right, that patients do have more suicidal ideation. I know that I have had to do actually more crisis interventions with few of my patients where I have had to do suicidality assessment and involving family members, right, and planning for safety. So we know that there is also, you know, potentially increased rates of suicides right now because of the isolation as well, right? So sort of it's hitting our patients in particular from multiple levels. So something definitely for us to be on the lookout. So, you know, overall, right, you know, the themes, right, that we see, the psychological effects, right, of COVID, right, we see this idea of living in limbo, right, as we discussed, right, yet again, right, our patients have done this already. So for some, this is really hard. For some others, actually, they feel like not much has changed, right? I have, you know, patients, and I'm sure you do too, you know, they love staying at home and playing video games. And now, you know, this is kind of encouraged, right? But, you know, for many, you know, this is again feeling stuck, worrying about wasting this limited precious years on quarantine and isolation. But of course, also worrying about infection very appropriately. The guilt, right, that, you know, others, you know, the potentially the burdens that they might be putting on others, existential losses and griefs. But again, also resilience and expertise, right? Some of the patients really feel that, you know what, I'm actually doing pretty well because now the rest of the world is catching up and doing what we have been doing forever, right? Some of the patients who were very self-aware, self-conscious about wearing the mask, obviously now the mask has a totally different symbol, but overall they feel like, well, now like many people are doing it, right? So it's actually not stigmatizing. On the other hand, right, for example, something that I work with my CF patients about what other people think about them when they cough in public. And now, obviously, you know, it's even scary to cough in public. So, but a lot of these patients, they do feel like, you know what, I've been doing infection control. And again, for the 6 feet, right, rule, like that's been present in CF world forever. So some of our patients actually feel very validated. That's why we even see some of the anxiety, patients with anxiety or even a CD doing better because they feel like the rest of the world is finally catching up, right, to their fears. And they feel like they're being a pros at this. I have done it once, I can do it again. And again, some people feel like, well, you know what, my life hasn't actually changed much. I'm being careful. I'm not seeing people who are sick. So, you know, and also appreciating time at home, time with their loved ones. So, you know, so yes, it's very hard, but I think also we do need to appreciate and build on the strength and resilience of many of our patients and often actually even learn from them as well. So some of the kind of other interesting aspects, right, particularly for our field, right, well, what about the alcohol use, right? You know, we know, you know, I mean, I know that reports have been here that alcohol sales have increased at some point to 40% of the usual norms, right? Trader Joe's was like selling out, you know, all the good, you know, tequila and beers and wines. So, you know, so people do drink more at home, but also in terms of the people who do have alcohol use disorder, right? You know, some people, you know, it really depends, right? For some people, they increase their use, right? And that's very worrisome. In one study, 17% of those people who were abstinent before, they have relapsed, right? And then, but some people are decreased. Right, so it's actually really, it will be interesting again to see. There's definitely people who have, for whom it's been much more difficult to stay sober because, you know, there's, you know, the rehabs programs not available, right? In-person AA is not available. The support system, the other activities, the work is not available. But for other people, you know, I have one transplant recipient whose actually major contraindication was his alcohol dependence. And he has done an amazing job before working on it, amazing insight, which has been very helpful. And he's been afterwards, year and a half out, and he's been able to abstain because he knows if he starts drinking, there is no returning for him point. But on the other hand, that fear of going to the store and actually getting the alcohol, or even if you get it and getting it from somebody else, even from delivery, it also kind of provides maybe a cushion. But we do know that patients have decreased access to rehab programs. And overall, there is definitely a concern in the community, like what does it mean for patients with alcohol use disorder and for patients with alcoholic liver disease, right? And are we gonna see increased need for liver transplants after, right, some years afterwards, after we come out from the pandemic, right? Are we gonna see increased levels of liver damage? I mean, potentially. And I think what also is interesting, and we might be seeing these patients more and more, right? But as I'm aware, there have been 2 patients so far who actually have had, right, transplantation for COVID-19, right? Both in Chicago. Very, amazing and interesting. So the first patient was Maya Ramirez, who was a 28-year-old woman who had a lung transplant on June 5th. And obviously this is from, just social media, so very widely available data. So there's no HIPAA violation because everybody knows this. And, she does, she was previously healthy before, but has shared, right, kind of, it's actually, as we know, the recovery has not been easy, right? So for people to think, oh my goodness, yeah, I can still get transplant. We know that this is not an easy solution, unfortunately, but it's there. And then there was another 60-year-old man who received his the second lung transplant on July 5th. And it'll be very interesting to see kind of, what happens afterwards. So what can we do, right? So, we have now this telecom, right? The telepresentations, of course, right? The telepsychiatry and telehealth has been monumental. It's a great way to reach our patients. Of course, it also has limitations. For some patients, it's just not the same. It's just really hard for them. And for providers to sit in front of the screen, right, and to be staring at the patients, there's not that same 3D interaction. I know that I have had to shorten, for some of my therapy patients with whom usually I would have an hour session, it's actually too much. So we have shortened to 30 minutes to kind of to avoid the Zoom fatigue. But it is available. It's actually, some patients are able to get more services because it was difficult for them to get 3 hours away to the center, and now it's so easy for them. So again, some patients have more access, right? There's sort of this telephone, right? And what we can do is, the regular, right, our interventions, right? Whatever we do as psychiatrists and psychopharmacologists and educators and therapists, and validation of the experience is very important. And for some patients, it's behavioral activation. It's really helping them to motivate themselves. Educations, right? Patients are looking up to us for the risk-benefit assessment, right? Am I being too anxious? Am I being too restrictive? Right? So we are, I always feel like we are the psychiatrists, transplant psychiatrists, or CL psychiatrists. We're often the translators of medicine for our patients because we have more time. And so they do come to us with those questions. So being knowledgeable is important. Screening, right? PHQ-9, GET7, but also screening for acute stress disorder, PTSD symptoms, for alcohol use, for suicidality. And then, things like support groups. I put it here sort of like, my picture, but this is a support group that I actually have been doing since March 13th, pretty much when lockdown started in California, through CFRI. It's our local organization, CF Research Institute. And it's at some point it was weekly. We would do, for 3 months, we did it weekly. And now we're doing it every other week, national support group for patients with CF and also actual lung transplant. So this is a place where people come, people relate. And now there are some old comers. So, we've been bonding and helping each other for 5 months at this point, and then new patients come in as well. But that's something we can do, like organizing support groups, right, for our patients across the territories. Refer patient connecting to virtual support groups as well, right? AA, right? The virtual AA, right? Facebook support groups, right? As we said, media can be dangerous, but there's also definitely, the connection. We know that, for example, the CF patients at Stanford and lung transplant patients at Stanford have their own support groups as well. Organizations, right? Kind of not only the transplant organizations, but also the chronic disease organizations that can also support patients. Wellness letter. So in the beginning of our pandemic, also our center, CF center, put out a wellness letter. And that's something that we do actually every few months anyway, but the emphasis was on the mental health in times of COVID. So we're just providing education and also just letting patients know that we're thinking about them, we're there with them, we're available. Multidisciplinary work, again, this is what we do all the time, right? But really collaborating and just because we cannot see each other as much in the hospital hallways, right? Our other clinicians, the surgeons and the pulmonologists and the nephrologists, right? We can, it's just as important for us to be talking and corresponding and making sure that we're supporting our patients together. And also each other, right? I know that other medical health professionals, look up to us, right? I know that our ICU physicians from the beginning kind of reached out to our group and said, okay, please provide the services to our fellows, right? So, you know, we are the gurus. At the same time, right, we are humans, right? This has been really hard for all of us, right? And we have to carry this, right, for many people. So really important to take care of ourselves and our families and providing, right, you know, boundaries in our work, right? And making sure that we're taking care of ourselves, right? Because if we do not, it's very hard to take care of somebody else. So self-care is really important, as hard as it is, especially nowadays. So this is what I have for today. And I guess at this point, we'll see if there are questions.
Thank you. Thank you very much, Dr. Sher. It's a wonderful talk. I think you gave us a lot of information, a lot of thinking about this process. It's been a challenge for all the psychiatrists, but also a big challenge for all the patients. I love these clinical cases that you express. I love these all concerns that they have. And of course, it's been difficult. We have a few minutes to have questions. I don't know if many of the audience have some questions. Dr. Escareño?
Hey, how are you this morning? Carlos, congratulate. Very enriching talk, Dr. Chair. Thank you for your time. Well, Latin America is a little bit different from the U.S. I personally train at Northwestern, a very, very good transplant center. Right now we are facing a lot of anxiety. I'm just gonna share a few things that I have been seeing here in the transplant field. One of them is that my team is not fully engaged. I have been having trouble because the most majority of physicians are not fully on transplant. They share other responsibilities. So right now they're overwhelmed with COVID. And the events that we have had, around transplantation, it has been difficult for me as a team leader to try to get them engaged in the case. So that has been one of the biggest problems, I think, and a lot of transplant centers in Latin America are going to be seeing this. So my first question is any strategy to cope with this staff that is tiring and overwhelmed with COVID, and that we need to get them re-engaged when we have a transplant event.
Yeah, and Dr. Escareño, just for my own knowledge, you are a transplant physician?
I'm a transplant surgeon, yes.
Surgeon, okay.
And the transplant director here.
Yeah, awesome. Okay. So yes, no, absolutely. And I think especially, early on when it was uncertain for us, right? Like, as I mentioned, like some of our, transplant pulmonologists, they're also ICU physicians, right? So sort of like, obviously taking care of ICU COVID patients, right? Obviously, like there's a conflict of interest right there. But, what I would say, definitely, engaging the support of the mental health providers in your center, but also in the community, right? I mean, I know that, here a lot of community mental health providers, social workers and psychologists, came together and made free services available, right, to frontline workers. So I don't know if there's kind of the same efforts are going on right now in Central America and Mexico, right? But it's sort of like, but it's really working with the psychiatry, right, department, right, sort of having focus groups first. What we have done, right, we've had kind of, focus groups and just group sessions for physicians, right? ICU doctors, ER physicians, ER residents, nursing staff, right? So having group sessions, we're just providing a space to vent and to validate and to normalize it, right? Because this is really scary, this is really scary. And we were there, at least was the fear kind of earlier on. One of the concepts, so I mean, there's not only the intense anxiety, but also watching kind of what the rest of the world has gone through. The concept that was very helpful for me was pre-traumatic stress disorder. So it's not just living in this, but it's vicarious trauma, but it's also anticipating what might happen if I get sick, if my loved ones get sick, right? So sort of like being traumatized by the idea of what might happen to you. So working with the psychiatry, having the group sessions, and then hopefully potentially identifying those people who are struggling more, right? And reaching out to them and connecting them, hopefully with like free mental health services. Again, if there are people who are available, and maybe, maybe also paid services, right? Because mental health services need to be paid as well, but see if the community providers can help in. And I think somebody as a director of the program, right? I think normalizing it, right? To just saying that like, this is what I'm feeling. Like, this is okay to reach out for help. This is very hard for us. This is not a sign, of weakness. So really addressing your own mental health needs, making it okay for the team members to address it. And that would allow them then to come together and support their patients. Because if you are not taking care of yourself and I'm not taking care of myself, I'm not able to be there for the patients. So as hard as it is, right? And there's so many patients who are suffering, and having this intense responsibility that we have to help, of course, every single patient, but also knowing that we have to save time for ourselves. That at some point you have to sleep, sort of focusing on those basics. You have to sleep, you have to eat, you have to like go for a walk or exercise, right? You have to adhere to your own medical routine to be able to be there. So like validate and normalize it for yourself, show an example for others, and then having these group sessions, focus groups, as well as individual sessions. And very happy to talk more about that as well, kind of offline.
And then my second question is, I have been having trouble, organs shortage in Latin America. It's a big issue right now because a lot of the hospitals that create organs or have donors are concentrated fully on COVID. Mm-hmm. So we have not had, the same amount of organs.
Yeah.
So recently in the past month or weeks, we had very high melders in the hospital that needed an organ within 72 hours. In Northwestern, meld 35 will get an organ within 72 hours. I mean, the phone didn't stop ringing, with offers. So, for my personal view, it was very hard coping this false expectancy of treatment in an era that the treatment cannot come because there is organ shortage. So it was very difficult for me to manage with the family the expectation of the organ coming. And sadly, one of them recuperated an acute liver failure, but the other one passed away waiting for the organ and waiting for the right time. So I definitely think, Carlos maybe should start working on the team and with the patients, setting this expectations that the organ is not coming. And for last, have you had in your team the talk to do lung transplant or not? And I know from firsthand the lung transplant at Northwestern with my colleagues, the patient was conscious and she was pushing for it. And I think that had them get together and make it happen. But has this happened, has this happened to you in Stanford? Somebody connected in ECMO, fully awake and being communicative, like, you have to solve this problem for me.
To be honest, I don't know. I've not heard of it. It does not mean that those conversations have not happened, but I'm not aware that has happened. And I don't know, I'm sure that would involve psychiatry for evaluation, and I've not heard of it. Doesn't mean it did not happen. Conversations have not happened. I mean, I'm sure looking at the Chicago experience, I'm sure like Stanford is itching, right? Like they do not want to be last, right? If that's the new thing. But, I know that we've had, definitely, and I've taken care of like a very sick ICU patients, right? Intubated, but yes, I've not personally been involved in those conversations. Going back to your other point, right, about, some patients are just unfortunately not going to make it because there are no organs, right? So I agree. So it's being frank, as hard as it is for all of us, especially for transplant physicians, right? Like transplant physicians, I know, do not want to talk about what, right? Like of course you want to save, you want to give that organ, you're a surgeon, right? But yes, being frank with psychiatrists, and involving palliative care, right? If that's available, right? Talking about death and dying, as scary as it is for all of us to do this, at the end of the day, patients and their families really appreciate it, right? Being frank, being supportive, and telling patients that we're still there for them. That yes, they might not get an organ and they might die here in the hospital at home. And yes, this is scary, and I'm sorry. I wish this were different. but we will be here for you no matter what, right? We will not let you suffer, right? So still that hope that they will die with dignity and comfort. And it helps the patient as hard as it is, but it also helps the family, right? Because then the grieving family, if there is that closure and they feel that still their loved one was taken care of in the best of the capacity, and maybe that's a dignified death, that helps them carry on.
Thank you. Thank you, Dr. Escareño. Thank you.
Thank you.
I have two questions. Well, one of mine and one of the Doctora Cristina Gonzalez. You mentioned, Dr. Sher, about the support groups. And I've been wondering if I should separate the patients that are waiting the liver, the kidneys, the lung, or all, I can make therapy, group therapy all together. What do you recommend? Or to separate the organs?
I think it depends on like what would be the, how many patients would attend, right? I think the best support groups are probably like 8 to 10 patients where they're, like there's potentially, right?
Yeah.
So, so I think if there's too many patients for that, then I think separating by groups, it makes sense, but you might want to start, right? Kind of, with the whole group and see how many patients show up. And then if there are too many, then kind of separate them. Because, right, sort of, it might be more urgent, right? Obviously, it's different waiting for lung versus waiting for kidney when you have a kidney dialysis and, right, and you're doing more or less okay, right? So, but I think of the group size.
Okay.
Yeah.
And the other question was, are you still applying these scales, like the SIPAT scale and the audit for alcohol? I mean, in these telepsychiatry interviews, are you still using that measures, that scales?
We're still doing the same evaluation. Of course, we have to adjust what's available to the patients, right? So, like if inpatient rehab is not available, or even if it's available, like it's probably not a good idea to send a patient there right now, but we're still applying it, right? And we always have the social workers, they do the first line, they do the SIPAT, and then any questions, they send those patients to us, right? So we're still evaluating. And if somebody is really still high risk, right? So I saw the patient is still lung transplant candidate, right? And he's still smoking tobacco and weed. It's still just as bad as it was before COVID, right? So if you're not able to quit with whatever limited resources available, as sad as it is, he's not going to be a candidate because, right? Like, the outcomes don't care during what time he was transplanted. So yes, so kind of being thoughtful about it, but still applying the SIPAT. But obviously now we're doing a lot of evaluation virtually, right? So that's interesting. It does change the dynamic a little bit. It makes it easy on patients on one hand, but again, you're missing that like 3D being in the room factor. Although there were cases, for example, I did have a patient, who, unfortunately was not able to connect to technology and also was, Spanish speaking. I don't speak Spanish. So, so that patient, I did come to the office with a translator, right? So kind of case by case, right? But virtual definitely changes it, but otherwise we're still applying the same algorithm actually.
Okay. Well, I don't know if you want to say something at the end of this session, Dr. Sher. Again, thanks for being here. I don't know if you want to share a final thinking, a final thought.
No, thank you so much, for having me and sharing this, this thoughts and this data with you. And, just will be nice meeting you guys and just will be thinking about you, hang in there. These are definitely really tough times. We will get through this. Hopefully we'll get stronger through this and we'll learn lots of lessons. And you definitely reach out if you have any follow-up questions about any of the ideas or what we have done or just further suggestions. I'm very happy to talk further offline. But
thank you very much. Thank you. A big hug
yes.
to Monterrey, to Stanford. Please say hi to Dr. Maldonado from all the psychiatrists from Mexico too. And thank you very much for all of you for being here. Have a good Friday. Have a good weekend. And thank you very much again, Dr. Sher. Have a good week.
Absolutely. My pleasure. Okay. Thank you.
Bye-bye.
Bye. Bye.
Gracias a todos por estar acá. Buen día.